Colorectal cancer. So today's topic is colon cancer and colorectal cancer or colorectal cancer, colon cancer and polyp. Objectives: by the end of the sessions, learners will be able to review the anatomy and physiology of colon and rectum, discuss the causes, pathophysiology, and manifestations of the following colorectal cancer, discuss the diagnostic, medical, and surgical management of colorectal cancer, applying nursing process including assessment, planning, implementation, and evaluation of the care provided to the clients with colorectal cancer. Physiology: the function of the large intestine is to get rid of food left over after the nutrients are removed from it, bacteria and other waste. This process is called peristalsis and can take around 36 hours. First, liquid and salt is removed from the waste as it passes through the colon. Then the waste makes its way to the sigmoid where it is stored. Once or twice per day, when the body is ready for a bowel movement, the waste is dumped into the rectum. So here we are discussing about the normal physiology of the colon, which we have the ascending, transverse, and descending colon, and then sigmoid colon, which will be end up into the rectum. So what is the function of large intestine? Is to get rid of the food which is left over after the nutrients एब्जॉर्प्शन. तो जब भी जो एब्जॉर्प्शन होती है न्यूट्रिएंट्स की वो हो जाती है, मुकम्मल हो जाती है कम्प्लीटली, तो उसके बाद क्या होगा कि जो जितने भी बैक्टीरियाज होंगे, अदर वेस्ट होंगे, वो सारे क्या होंगे, वो भी जो है वो फ़िल्टर हो चुके होंगे. तो उसके बाद क्या होगा कि जो हमारे पास लेफ़्ट ओवर प्रोडक्ट होगा उसको जो है कॉलन ने बाहर निकालना होता है, उसको डंप आउट करना होता है. और उसके लिए वो क्या करेगा, पेरिस्टाल्सिस की जो है वो हेल्प लेगा. पेरिस्टाल्सिस क्या होती है, मूवमेंट होती है जो कि बोवल की मूवमेंट होती है बेसिकली, ताकि क्या कर सके, बोवल को एक कॉलन के पार्ट से दूसरे कॉलन में लेके जा सके और देन उसको टर्मिनेटिंग पॉइंट पे एलिमिनेट कर सकें. ठीक है. तो वंस और ट्वाइस पर डे व्हेन द बॉडी इज़ रेडी टू फॉर अ बोवल मोमेंट, वेस्ट इज़ डम्प्ड इनटू द रेक्टम एंड द पेरिस्टाल्सिस, द प्रोसेस ऑफ पेरिस्टाल्सिस टेक्स अराउंड 36 hours. Colorectal cancer, CRC, also known as bowel cancer, is the development of cancer from the colon or rectum parts of large intestine. A cancer is the abnormal growth of cells that have the ability to invade or spread to other parts of the body. So colorectal cancer is also known as bowel cancer, which we can say that the cancer of the large intestine is the development of cancer from the colon or rectum. तो कॉलन में भी हो सकता है, रेक्टम में भी हो सकता है, जो कि पार्ट्स हैं लार्ज इंटेस्टाइन के. अ कैंसर इज़ द एबनॉर्मल ग्रोथ. सो वी आर डिस्कसिंग अबाउट CA. कैंसर बेसिकली इज़ द एबनॉर्मल ग्रोथ और द मेलिग्नेंसी of the cells that leads to the condition of cancer. So what happens when the abnormal growth of the cells happen? They that have the ability to invade or spread to the parts of the body. तो क्या होगा कि जब भी जो एबनॉर्मल ग्रोथ होगी, जो हमने पहले भी कैंसर्स जो हमने डिस्कस किए हैं डिफरेंट पार्ट के, डिफरेंट ऑर्गन्स के, जब कैंसर हमने डिस्कस किया तो हमने ये बात की है कि मेलिग्नेंसी हो जाती है, हाइपरप्लास्टिक हो जाती हैं, डिस्प्लास्टिक हो जाती हैं, हाइपरप्लास्टिक होते हैं और एंड एट दी एंड मेटाप्लास्टिक हो जाते हैं. और उस मेटाप्लास्टिक स्टेट की वजह से क्या होगा कि ये जो है वो दूसरे जो पार्ट्स होंगे उनको इन्वेड करेंगे और स्प्रेड करने लग जाएगा डिफरेंट पार्ट्स ऑफ द बॉडी में, या फिर जो कॉरस्पॉन्डिंग नियर बाय प्रोडक्ट जो हमारे पास स्ट्रक्चर्स होंगे उनमें स्प्रेड होने लग जाएगा. इट मे स्टार्ट एट बेनाइन पॉलिप. तो ये स्टार्ट कैसे होगा, बेनाइन पॉलिप पे, बट मे बिकम मैलिग्नेंट, इन्वेड एंड डिस्ट्रॉय नॉर्मल टिश्यूज एंड एक्सटेंड इनटू द सराउंडिंग स्ट्रक्चर, जो कि हमने बात रिपीट की है. कैंसर सेल्स में माइग्रेट अवे फ्रॉम द प्राइमरी ट्यूमर एंड स्प्रेड टू अदर पार्ट्स ऑफ द बॉडी, मोस्ट ऑफन टू द लिवर, पेरिटोनियम एंड लंग्स. तो नियर बाय जो पार्ट्स होंगे जहाँ पे कैंसर सेल्स जो होंगे, कोलोरेक्टल कैंसर सेल्स, वो माइग्रेट करेंगे. वो कौन से हैं, लिवर, पेरिटोनियम एंड लंग्स. The incidence increases with age. The incidence is highest in the people older than 85 years and is higher in people with a family history of colon cancer and those with inflammatory bowel disease or polyps. Inflammatory bowel disease such as Crohn's disease and ulcerative colitis. Risk factors. The possible risk factors for colorectal cancer are: being elderly, the older you are, the higher the risk is. A diet that is very high in animal protein, a diet that is very low in dietary fiber, a diet that is very high in alcohol consumption, women who have had breast, ovary, and uterus cancers, family history of colorectal cancer, patients with ulcerative colitis, inflammatory bowel disorder, being overweight or obese. Smoking is significantly associated with an increased risk for colorectal cancer and death. Being physically inactive, presence of polyps in the colon, rectum. Untreated polyps may eventually become cancerous. So the first of all risk factor is about the age. The most common age is the older ones. Number second is a diet that is very high in animal protein. If a person is taking increased intake of animal proteins, low dietary fiber, usage of low green vegetables, then increase intake of alcohol, then a woman who had a breast cancer, uterus or ovary cancer, family history, ulcerative inflammatory bowel diseases, being obese, being physically inactive, which means decreased peristalsis or obstruction of the bowel movement or the bowel, presence of polyps in the colon and rectum. Untreated polyps may eventually become cancerous. So that's why this is called the colorectal polyps or the colorectal cancer. Clinical manifestations: changes in the bowel habits. Most common presenting symptom: passage of blood in or on the stool. Second most common symptom. Most common presenting symptom is changes in the bowel habit, and blood in the stool is the second most common symptom. Unexplained anemia, anorexia, weight loss, and fatigue. Right-sided lesions are possibly accompanied by dull abdominal pain and melena, black tarry stools. Left-sided lesions are associated with obstruction, abdominal pain, and cramping, narrowing stools, constipation and distension, and bright red blood in stool. So right-sided lesions are possibly accompanied by dull abdominal pain. अगर क्या होगा कि राइट साइड पे लीजन्स होंगे तो वो क्या होगा कि डल एब्डोमिनल पेन और मेलिना के जो है उससे कंपनी होंगे, जबकि जो अगर लेफ़्ट साइड लीजन्स होंगे तो वो एसोसिएट किसके साथ करेंगे कि एब्डोमिनल पेन होगी, ऑब्स्ट्रक्शन के साथ बेसिकली वो करेंगे, जिसमें एब्डोमिनल पेन होगी, क्रैम्पिंग होगी, नैरोइंग होगी, कॉन्स्टिपेशन, डिस्टेंशन और ब्राइट रेड ब्लड इन स्टूल होगा, क्योंकि ऑब्स्ट्रक्शन होगी तो टीयर होने के, डैमेज होने के जो है वो चांसेस बढ़ जाते हैं, तो ब्राइट रेड ब्लड होगा। और दूसरी तरफ जो है वो राइट साइड लीजन्स में क्या होगा कि डल एब्डोमिनल पेन होगी, जबकि जो अगर लेफ़्ट साइड लीजन्स में देखें तो क्या है, क्रैम्पिंग, यानी कि डल पेन नहीं होगी, शार्प एकिंग पेन इसको बोल सकते हैं। और उसमें क्या है, मेलिना है, यानी कि हमने पहले बात जैसे की हुई है कि मेलिना में बेसिकली क्या होगा कि जब जो ब्लड होता है वो डाइजेस्ट हो जाए इंटेस्टाइन में ही, डाइजेस्टिव फूड के साथ जो फूड होता है, गैस्ट्रिक कंटेंट होता है, उसी के साथ डाइजेस्ट हो जाए, तो वो जब हमारे पास ब्लैक एक स्टूल आएगा, टारी स्टूल, फाउल स्मेलिंग स्टूल आएगा, तो उसे क्या बोलेंगे कि मेलिना की स्टेट है। और दूसरी तरफ क्या है कि ब्राइट रेड ब्लड इन स्टूल है, यानी कि जैसे कि हमने बात की थी कि मेलिना होता है, हेमेटोमेसिस होती है और हेमेटोकीजिया होता है। तो हेमेटोकीजिया में क्या होगा कि ब्राइट रेड ब्लड इन स्टूल होगा। तो इस तरह से जो है वो राइट साइड लीजन्स और लेफ्ट साइड लीजन्स जो होंगे, यानी कि पॉलिप्स जो होते हैं जिसको हम बोल रहे हैं, उनको क्या कर सकते हैं, डिफरेंशिएट किया जा सकता है, सिग्निफाई किया जा सकता है। रेक्टल लीजन्स एसोसिएटेड विद टेनेस्मस, ineffective painful straining at stool, rectal pain, feeling of incomplete evacuation after bowel movement, alternating constipation and diarrhea and bloody stool. So rectal lesions are associated with, वो हमने किसकी बात की थी, कोलन जो लीयंस होंगे, कोलन पॉलिप जो थे उनकी बात की थी कि राइट साइड लीयंस एंड लेफ्ट साइड लीयंस. एंड नाउ वी आर टॉकिंग अबाउट द रेक्टल लीयंस विच आर एसोसिएटेड विद इनफेक्टिव पेनफुल स्ट्रेनिंग एट स्टूल, rectal pain, feeling of incomplete evacuation after bowel movement, feeling of urgency, or feeling of the urge to defecate again even after going to toilet and having a bowel moment, alternative constipation and diarrhea and bloody stool. Signs of complications: partial or complete bowel obstruction, tumor extension and ulceration into the surrounding blood vessel, perforation, abscess formation, peritonitis, sepsis or shock. सो साइंस ऑफ कॉम्प्लिकेशन बेसिकली क्या होंगे कि जब पार्शियल और कंप्लीट ऑब्स्ट्रक्शन हो जाएगी और जो पॉलिप्स हैं उनके एक्सटेंशन होने लग जाए और अल्सरेशन होने लग जाए. सो बेसिकली द अल्सर्स विल बी लीड टू व्हाट, perforation, and the perforation will be when the ulcers become perforated, it means that they are becoming abscesses. ठीक है. And with the formation of abscess, what will happen, as we have discussed in the previous lecture, that the abscess formation will lead to the tunneling of the structure, which will drain the fluids or the waste product or any other substance or the liquid or fluid into the peritoneal cavity, which leads to peritonitis, inflammation of the peritoneum, the lining of the abdominal cavity, which leads to sepsis. And when the sepsis increases, it leads to septic shock, which means the infection is going to spread or has been spread into the body, which leads to septic shock. In many instances, symptoms do not develop until colorectal cancer is at an advanced stage. Sometimes what happens, the symptoms when the patient or the disease is not symptomatic, it is asymptomatic, and the symptoms do not develop until colorectal cancer is at an advanced stage. Diagnostic evaluation: we have the diagnostic criteria to evaluate or to diagnose the colorectal cancer. So first we have the abdominal and rectal examination, in which we involve fecal occult blood testing, barium enema, proctosigmoidoscopy and colonoscopy, biopsy or cytology smears. So these are the procedures we have discussed, so no need to discuss them again. CEA, carcinoembryonic antigen test studies, should return to normal within 48 hours of tumor's excision. Reliable in predicting prognosis and recurrence. So CEA is a procedure which is reliable to predict prognosis and recurrence of the colorectal cancer. Medical management: treatment of cancer depends on the stage of disease and related complications. Obstruction is treated with IV fluids and nasogastric suctioning with blood therapy if bleeding is significant. In the case of anemia, supportive therapy and adjuvant therapy, for example chemotherapy, radiation therapy, immunotherapy, are included. Surgical management: surgery is the primary treatment for most colon and rectal cancers. The type of surgery depends on the location or the size of tumor, and it may be curative or palliative. Cancers limited to one side can be removed through a colonoscope. Laparoscopic colotomy with polypectomy minimizes the extent of surgery needed in some cases. Assessment: obtain a health history about the presence of fatigue, abdominal or rectal pain, past and present elimination patterns, and characteristics of stools. What we will take in the history: about the presence of the fatigue, abdominal or rectal pain, the pain score, past and present elimination pattern, if the patient is having constipation from few months, or the patient is having diarrhea from few months, or the patient have chronic constipation, if the patient pass the stool after 8 to 10 days. So these will be the elimination patterns and characteristics of stool. The stool is soft, the stool is hard, the stool is watery, or the stool is blood tinged, or the stool is black, the stool is tarry, the stool is foul smelling. So these will be the characteristics of stool. Obtain a history of inflammatory bowel disease or disorder or colorectal polyps, a family history of colorectal disease, and current medication therapy. Assess dietary patterns including fat and fiber intake, amount of alcohol consumption, history of smoking. Describe and document a history of weight loss and feeling of weakness and fatigue. Auscultate abdomen for bowel sounds. Palpate for areas of tenderness. For bowel sound, what will we have? We will auscultate abdomen for the tympani. Palpate for the areas of tenderness, distension, and solid masses. Inspect solid for a stool for blood. Nursing diagnosis: imbalanced nutrition, less than body requirement related to nausea and anorexia. Risk for deficient fluid volume related to vomiting and dehydration. Anxiety related to impending surgery and diagnosis of cancer. Planning: the major goals may include attainment of the optimal level of nutrition, maintenance of fluid and electrolyte balance, reduction of anxiety, learning about the diagnosis, surgical procedures, and self-care about the discharge, maintenance of the optimal tissue healing, protection of the peristomal skin. So what will be happen in the planning? That the major goals will be the attainment of the nutrition, fluid and electrolyte balance, reduction of anxiety. These the planning basically based on the nursing diagnosis about the patient condition. So the protection of peristomal skin, nursing intervention, preparing patient for surgery. Physically prepare patient for surgery, diet fiber in calories, protein and carbohydrates, and low in residue. Full liquid diet 24 to 48 hours before surgery, or parenteral nutrition if described. Parenteral nutrition is basically the nutrition which is given to the person who is unable to take oral feed due to many physiological or pathological conditions, such as if the patient is in the trauma in CVA, or if the patient have mouth ulcers, or if the patient is passed with the endotracheal tube. So these are the major conditions in which what will happen, that parenteral nutrition is prescribed. So basically parenteral nutrition is the route through IV intravenous route through which the patient's need of nutrition or demand of nutrition is fulfilled. Administer antibiotics, laxatives, enemas, or colonic irrigations as prescribed. Perform intake and output measurement of hospitalized patient, including vomiters, nasogastric tube, and IV fluid and electrolyte management. So we will discuss. We will monitor the patient input and output. The input and output involves whatever the infusion is. If the patient is transfused with blood, how much the patient orally take the liquid, which will be anything: milk, juice, water, anything, or any drainage, as we have discussed here, vomiters. So all the input and output measurement of the hospitalization are mandatory. Observe for the signs of hypovolemia, tachycardia. So hypovolemic signs include tachycardia, hypotension, decreased pulse volume. Monitor hydration status. So basically why we are observing the signs of hypovolemia, to because if the patient input and output measurement is completely done and performed well, then what will happen, that the chances of hypovolemia and hypervolemia will be reduced. But in the case of hypovolemia, when the when the fluid volume in the body get reduced, we have the symptoms of tachycardia, hypotension, decreased pulse volume. Monitor hydration status, skin turgor and mucosal membrane. Monitor for the signs of obstruction or perforation, increased abdominal distension, loss of bowel sounds, pain or rigidity. So loss of bowel sounds means that there is no bowel movement, no peristalsis, pain or rigidity, and increased abdominal distension due to constipation, due to peritonitis. Providing emotional support. Nursing first of all, the nursing intervention is the preparing patient for surgery. So what we have discussed here, that we will keep the patient on parenteral nutrition for the procedure of surgery, or if the patient is unable to take oral medications or oral feed, observe the signs of hypovolemia, hydration status, obstruction or perforation, signs of obstruction or perforation, and monitor input and output. Providing emotional support, assess patient's level of anxiety and coping mechanisms, and suggest method for reducing anxiety such as breathing exercises and visualizing a successful recovery from surgery and cancer. So we will provide the emotional support to the patient, maintaining optimal nutrition. Advise patient to avoid foods that cause excessive odor and gas, including foods in the cabbage family, eggs, fish, beans, and high cellulose products such as peanuts. Non-irritating foods are substituted for those that are restricted so that deficiencies are corrected. Suggest fluid intake for at least 2 liters per day. So basically, if the person is over so if the person is in the state of bleeding, then what will be happen to the patient, that if the person is taking red fruits or vegetables, then we will be unable to differentiate between the blood or the vomiters, that the blood is in the vomiters, or the blood is red because of the fruits or the vegetables that he has taken. Maintaining fluid and electrolyte balance, record intake and output, and restrict fluids and oral food to prevent vomiting. Monitor serum electrolytes to detect hypokalemia and hyponatremia. Assess vital signs to detect signs of hypovolemia, tachycardia, hypotension, and decreased pulse volume. Assess hydration status and report decreased skin turgor, dry mucosal membrane, and concentrated urine. Encourage patients to verbalize feelings and concerns, provide a supportive environment and attitude to promote adaptation to the lifestyle changes related to stoma care. Stoma, which we have done to the patient, if the patient have colostomy. Monitoring and managing complications before and after surgery. Observe for symptoms of complication, report and institute necessary care. Postoperatively examine wound dressing frequent during 24 hours. Checking for infection, hemorrhage. Now the expected patient outcomes or the evaluation. Consumes a healthy patient will consume a healthy diet and maintain fluid balance. Experience reduced anxiety. Patient learns about diagnosis, surgical procedure, preoperative preparation, and self-care after discharge. Patient maintains clean incision, stoma, and perineal wound. Patient verbalizes feelings and concerns about self. Patient recovers without complications. So this is the topic of colorectal cancer.